past, present, and emerging, and really acknowledge that they are the traditional owners of the lands, of the waters across and lands across Australia. I also want to pay my respects to any Aboriginal or Torres Strait Islander people, including members of the Stolen Generation. So we'll just start with a little bit of housekeeping regarding Zoom. At the conclusion of the talk, I'll introduce our speaker in a moment, but our speaker will go for about 40 minutes. And at the conclusion of that, we'll have a few minutes for questions and answers. So if you do have any questions, please feel free to put them through in the chat function. The chat tab will be open at the bottom of your screen throughout the presentation, or feel free to just put your virtual hand up and I can come to you when we get to that question time. We're recording the seminar today and we'll be uploading it to the website in a few days' time. So please keep in mind, if you turn on your video and ask a question, that your image will be included in that video. So without further ado, I'd like to introduce Dr. Terry Chong. So Terry Chong is a Senior Research Fellow in Old Age Psychiatry. He has a joint appointment between the University of Melbourne Academic Unit for Psychiatry of Old Age and also at St Vincent's Hospital, Melbourne. Terry is, if he's not busy enough, he's also a PhD candidate, and his research interests include dementia risk reduction, anxiety in later life, physical activity, and use of technology to facilitate interventions. He holds appointments as consultant psychiatrist in St Vincent's Hospital, Melbourne, Epworth Healthcare, and medical and mind weight loss. And his current clinical work is with the Healthy Ageing Service at St Vincent's Hospital, Melbourne. So as I said, it's my delight to introduce Terry today. And Terry, you're going to be speaking to us about exercising your worries away, the potential of physical activity interventions to reduce anxiety. So over to you, please, Terry.
Great. Thanks so much for the introduction, Catherine, and thank you for the invitation to speak today. It's a pleasure to be here and great to see you all virtually. And it's quite a nice opportunity for me because I get to present about topics that are of interest to me, which is always fun. And I know that I can say that anxiety is of great interest, given that I think it's something that many people experience, and unfortunately some people more than others. And I think there has been quite a bit of anxiety in the last few years due to many, many reasons, including the obvious ones. And I also have quite an interest in physical activity. So this was a nice way to combine both of these interests. And I hope to take you through some of our work in this area and some of our upcoming work in this area over the next half an hour. So just by way of introduction, Catherine's already very generously introduced me. And as she said, I work clinically at St Vincent's Hospital, and it's a joint appointment with the University of Melbourne Academic Unit for Psychiatry of Old Age. Also involved in a startup called Medical and Mind Weight Loss, as well as doing some work which is quite small these days at Epworth Healthcare. And physically based at St George's Hospital, which was the photo in the previous slide. So just going through, I thought it's always nice to start a talk with a definition. And so thinking about anxiety, I thought, well, we'll have a look at the Oxford English Dictionary and see what that says. And it describes a feeling of worry, nervousness, or unease about something with an uncertain outcome. And I think that's something that is fairly close to what we think about in a kind of clinical setting as well. So there's a lot of overlap with the English definition. And the derivation is also really interesting. So it comes from the Latin word to choke. And I think that's quite poignant in that it's already talking about some of that physical overlap that is experienced in anxiety. And so what does anxiety look like? So I used to kind of talk about this and describe this, but I've recently seen this really good video by Beyond Blue. So I thought I'd share that instead so that you can have a break from listening to my voice. So I'll just put that up. Hopefully it all works.
Anxiety. It's a word used often these days. But what is it? And what's the difference between feeling anxious and an anxiety condition? When you perceive a threat, you might feel uneasy, worried, nervous, distressed, or even scared. This is anxiety, and it's a natural and healthy response to situations you think may be harmful. But if these feelings hang around, pop up with no apparent reason, or start to impact your day-to-day life, it could be the sign of an anxiety condition. Anxiety conditions are really common. There are plenty of different types, and different people experience them differently because we're human. But what causes an anxiety condition? It could be any number of things, or a combination of them, such as a big life change, a hugely stressful event, the breakdown of a close relationship. It could be that there's a history in your family of people experiencing mental health conditions, that you experienced trauma when you were younger, or that you're dealing with ongoing physical illness or pain. While these are some of the main known causes of an anxiety condition, they aren't the only ones. What's most important is to understand that an anxiety condition is treatable, and it's worth talking to someone about.
So I was really pleased to stumble onto that video because it seemed to summarize what takes me ages to say in a nice 1 minute graphic, which is very helpful. So in terms of the context that we're in with anxiety, one of the things that has also made me interested in anxiety is that it's been recognized, especially in later life, as the Cinderella of psychiatric disorders, and is often overshadowed by the focus on the Ds, depression and dementia, and actually receives little attention in research in the clinical domains. Not to say that the other conditions don't deserve a huge amount of focus because of the impact they have, but also that anxiety is often neglected, even though it is the most common of the types of mental health conditions, and also causes significant distress and disability in people who it affects. So we felt quite strongly about this, and we actually wrote an editorial a couple of years ago now about why we thought that it was important to worry more about anxiety. And so I've just put that up as a reference if there's anyone in the audience who feels the same way and would like to see what we thought. And one of the figures that we included in that paper was just around a comparison of cumulative publications in Medline, kind of as a proxy marker for the research attention that conditions are receiving. And so in the yellow line, we have later life depression in mesh terms from when Medline started to about 2019 or midway through. And in the blue line, we have the same for later life anxiety. And you can see there's a big difference. And in fact, if we look at where anxiety in later life was up to in 2019, it was about the same as 25 years ago with later life depression. And so it gives a bit of an indirect kind of inkling about the relative attention that the conditions receive. So just by way of a bit of revision, I'll introduce two models or two concepts that I like to think about when I'm working with people as the role that I have as a psychiatrist. And so the first one is the biopsychosocial model, which was coined by George Engel some years ago now. And it places me in the middle, as you can see, and then it has biopsychosocial around me. And these factors are all kind of impacting on my health. And that's mental health as well as physical health. And in fact, social should actually be a bigger circle now, because it's become something that's encompassing more and more. So social, cultural, spiritual, and there are more other components that can be added to that too now. So if we go through these, and if I was in the room with you, I'd ask the volunteers, but it's a little bit more difficult to do that on Zoom. So if I think about social factors and impact on my health, well, it could be things like I've lost my job, or it could be that something good has happened at my footy team, or it could be that my spirituality is quite a protective factor for me and quite a support for me. In terms of psychological factors, it could be around my personality style, and I know that I would respond to stress differently to a person sitting next to me, and some things that affect them might not affect me, some things that affect me might not affect them. So I think our personality style and how we cope with things has an impact on what happens. As an example. And then in terms of biological factors, we can think of things like genetics, medical conditions, drugs, and so on. So there are all these things that are having an impact on our health, mental and physical. And so it's quite important to think about all of these things when we are working with somebody who's experiencing a mental health condition. And the other model I like to put up is the stress vulnerability model. So you can see the squiggly line, which is my attempt to draw the roller coaster of life that we are all traveling on. And throughout life, we have these biopsychosocial stresses that are pushing down on us all the time. And we also have biopsychosocial resilience factors that are helping to keep us afloat and keep us going. And my kind of simple conceptualization of a mental health condition is when the stressors overwhelm our resilience, then that can push us into having a mental health condition at that point in time. And it can be for a short period, it can be for a longer period of time. And so I think it's really important also to think of conditions as a continuum. So we can all line up if we're in the same room from, in order of heights or in order of how far we live from the Royal Melbourne Hospital where NARI is based and the academic unit is based, or we could line up from most anxious to least anxious, and that can change too. So if you're doing a talk right now and presenting, you might be higher up on that spectrum, or you might, or for whatever reason, you might be on another side of that continuum. So we all exist somewhere on this continuum. We move around on this continuum, and that's kind of part of being human, that there is this variation. So that kind of leads to that question of when does something become a disorder according to something like the DSM-5. And usually there are two criteria, and it's usually one or the other or both. And so one criterion is around the amount of distress that it causes. So if it causes a huge amount of distress, then that is when it would meet criteria, or when it impacts significantly on our function. So when we can't do the things that we want to be able to do. And when either of those things happen, as well as the other criteria, but when either of those things happen, then that's when it becomes a disorder. And that's when it's important that a person can receive help, whether it's psychological, social, or biological help. And we also need to be careful not to pathologize normal human experience. So that's another thing that is really something that we always have to keep in mind, that it is normal for us to feel sad at times. It's normal for us to grieve. It's normal for us to feel happy, and it's normal for us to feel angry. And we don't want to fall into the trap of labeling things as pathology if they're part of our normal human experience of life. So we have to be thinking about that as well when we support people, that it isn't automatically a kind of pathological condition. And we want to avoid having a cookbook. So the DSM-5 is useful for things like research and having a common language, but it's certainly not to be used just to put people into boxes. It's so much more important to understand the person that we've got in front of us, rather than trying to fit them into a category or a box, which is very unhelpful. So is anxiety a good or bad thing? Usually when I ask this question, people do say it can be both, which is kind of the correct answer. And I discuss this in a way that our brain directs this staying alive machine, and evolution has meant that we're pretty good at that, generally speaking. We try very hard to stay alive. And if we are in danger, our body makes sure that we don't ignore it. So we have this fight, flight, sympathetic nervous system response to a threat or a perceived threat, where we have all these physiological changes in our body to make sure that we have the best chance to fight the lion that's jumped out at us or run away from it. And if we are in that dangerous situation, we do notice it. So in kind of 2023 in suburban Melbourne, it might be that we're about to cross the road and then a truck goes past us at high speed, very close to us, and we get all that fight flight response, all the heart pounding and the hyperventilation, and we feel a bit shaky and a little bit lightheaded and so on. We get that response. It still happens, and we can't really ignore it. It's a very powerful response. And in fact, people who were able to ignore it weren't the ones that survived to then have us as their descendants. So we inherit these really powerful staying alive, fight, flight responses. The big problem is, though, is when we have these strong responses in a situation which is not actually dangerous. So if we're just at the supermarket going about our shopping, looking for the breakfast cereal that's on our list, and then we have this response, then it's obviously the wrong time to have this response, and it feels awful. Imagine having that sort of response, which people experience as a panic attack in that sort of environment. So I often talk about anxiety being on a dial and how we need to have it at the right level. And that's what the Yerkes-Dodson curve on the next page talks about. So I talk to people that I see about having the dial set at the right level. If we have too little anxiety, if it's turned down too much, then we don't really function at our best. If we have anxiety turned up too much, then we're just overwhelmed and we can't even think straight. And I often use a footy analogy. In the grand final, the coach's job is to basically get their team performing at their peak, which means that they have to be revved up enough to not be at that lower end where close enough is good enough, doesn't really matter, but not revved up too much where they're making silly decisions and giving away silly free kicks or 50-metre penalties for no reason. So they've got to be in that optimal zone, and that's what we're trying to do day to day as well. We want to have a good level of anxiety that's not too much and not too little. Oops, sorry. And so I think one of the other messages that I emphasize is that sometimes we can become immune to stories of anxiety that are told to us, but I think we can empathize. We've all experienced it to some extent, whether it's standing in front of 1,000 people somewhere where you have to give a talk or sing, or whether it's trying to cross the road and the truck comes much too close to you. There are lots of different situations where we've experienced that anxiety, and if we magnify that, we can kind of get a sense of what our patients are going through. I put this up more for completeness, but if we're looking at DSM-5, these are the categories that exist in the anxiety chapter. So There are specific phobias, specific fears about certain things, whether it's spiders or heights or needles or blood, to social situations and that fear of negative evaluation. The panic attacks were spoken about, agoraphobia, where you're fearful of being trapped somewhere where you can't escape. Generalized anxiety, which is anxiety and worry and stress over multiple things of daily life. And then anxiety can also be due to a medical condition, for example, a thyroid condition, or taking prednisolone, steroids, etc., or induced by a substance. So that's the broad categorization. So that was actually quite a long intro, so I should get on my bike, so to speak, and get into the physical activity side of things. So a bit of a pet interest of mine. So there is emerging evidence that physical activity interventions may benefit anxiety disorders. There was a nice systematic review meta-analysis by Stubbs and colleagues published, and then another one which looked at clinically significant anxiety. So a bit of nuance, but a slightly different definition to an anxiety disorder. And that was they were both studies in the general adult population. If we look in later life, there isn't much out there yet, unfortunately, and this is something that often happens in research, that we have this very ageist view which needs to change. And I think there are many in this room who are advocating for this sort of ageism to change, and hopefully we can make more inroads into this. One of the studies found that one of the reviews, found that the studies were too heterogeneous for a meta-analysis, and another one found some support for physical activity for anxiety. But both of these reviews looked at studies that used the physical activity in people who didn't have anxiety disorders or necessarily elevated levels of anxiety. So it was a different type of population. If we flip things around, there's now been a meta-analysis of prospective cohorts which show an association between high self-reported physical activity and lower chances of developing anxiety. So that's a good thing, going the other direction. And there's also a but. So anxiety can be a barrier to engaging physical activity. And there's this concept of exercise anxiety, whereby people who are doing exercise can actually find it hard to tell the difference between the anxiety symptoms and the symptoms that you get from exercising, like feeling short of breath, or a bit lightheaded, or a bit tense or sore, or a bit shaky. And so that's always or can often be a tricky thing. So just meta-analyzing those studies that or those reviews that I just showed in the previous slide, showing their forest plots. So the first one here is the Stubbs meta-analysis, which had those six studies. It showed that exercise was effective. And then the Aylett review, with the top one being exercise was effective, and the second one, the bottom one, showing that high intensity was more effective than low intensity in their review. So promising signs. We thought, and this was part of the PhD that I'm still doing, we thought we would have a look to see if there's anything more that's come out. And we broadened it a bit to anxiety disorders and subthreshold anxiety disorder, and we broadened the age range to midlife and late life, because there is a bit of overlap, I think, between midlife and late life, and certainly overlap in terms of the period of time where a lot of chronic health conditions can begin. And so that kind of intervention period is really important in terms of changing health outcomes. We found many, many things in our search, but unfortunately only ended up with 4 randomized controlled trials that met our criteria. So that was a bit disappointing. And I start with the quality assessment, which was the Cochrane risk of bias tool. And one of the things that does stand out is that there's quite a bit of uncertainty in terms of risk of bias in at least 2 of the trials, whereas the other 2 were a bit clearer with having less risk of bias. So we had this issue of not finding very much, and then finding studies which are varying quite a bit in terms of risk of bias and as a proxy for quality. In terms of the results themselves, they did, at least 3 of them did show some encouraging results for using physical activity or exercise in anxiety in midlife and late life. In fact, 1 of the studies was midlife and 3 of them were in later life. So hopefully, at the very least, we have drawn attention to the area and have inspired more studies. I put this up because I read this recently and I found this really interesting. It's a term that was coined, I don't know whether it was by this group, but they talk about exokines, which have been defined as signaling moieties, I can't even say that word, released in response to acute or chronic exercise, which seem to have all these beneficial effects throughout the body, which is really great. It's a great advertisement for exercise and improves cardiovascular disease, cognitive decline, obesity, cancer, type 2 diabetes, health span, longevity, and resilience. So an amazing pill, if it was a pill. So again, reinforcing the usefulness of what's being done. So how about guidelines? What do the guidelines say? Well, given I'm a psychiatrist, I would refer to the Australian and New Zealand College of Psychiatrists. And this is the first part of their flowchart for treating anxiety. So apart from the usual thing of assessment, which is comprehensive, you would be providing advice on lifestyle, and that includes exercise, which is great to see, addressing substance use and providing education, and then watchful waiting and review. And sometimes an assessment and education makes a big difference already to a person's anxiety, because they could be experiencing all of this, not knowing exactly what it was or feeling that they were going crazy or something like that. And knowing about it is quite a useful step. The next step would be around treatment planning, which is a collaborative process with the person in front of us and thinking about all their particular aims and preferences and what they're needing. And in terms of the next steps, I didn't show the whole flowchart, but just up to this point, which is based on severity. And we think about cognitive behavioral therapy, which has the most evidence for psychotherapies, and that's particularly used especially by itself in the mild range, and then in the moderate range, it's again used by itself, or else medication if there's a preference for medication, or a combination of the 2. And then in the severe end, it's usually a combination of those 2 things. So I put this up more as reference, but essentially it just shows in words what was on the previous flowchart. And this is using generalized anxiety disorder as kind of our prototype or prototypical anxiety condition. So I won't go through it because it doesn't really add anything to the flowchart. So what about later life? So again, I mean, I sound like a broken record, but this is a 64-page clinical practice guideline, and I found 3 paragraphs on older adults. So I don't think I need to say much more to that point. But they do talk about the fact that the efficacy studies of CBT and medication are also good in older adults. They've also tried the digital CBT. We have to keep in mind there can be a digital divide based on age and generations for some people. It's certainly not a blanket thing. And also they talk about medications and the increasing risk of side effects with medications as we get older, and so keeping that in mind. I put this up because colleagues from Nari and the Melbourne Aging Research Collaboration and I did write a commentary on the fact that clinical practice guidelines should be more inclusive and aging relevant. And so we're hoping that that we see more attention paid to the needs of older people in our guidelines across the board, across specialties, across disciplines. So the next thing to speak about is the Excel study. And again, I was thinking of playing a video, and maybe I'll play the video because Becca Moorhead, who was the research assistant who voiced this and coordinated much of the study, explains the study much better than I do. And this, actually, I'll just play it given the time because she explains it more succinctly than I do. And so that'll be more efficient.
This is a short video about the Excel study, a pilot intervention implemented by the Academic Unit for Psychiatry of Old Age at the University of Melbourne. In the Excel study, we trialled a 12-week home-based physical activity intervention with people aged between 45 and 80 years old. We targeted people who had changes to their memory and had mild to moderate symptoms of low mood, anxiety, or stress. We were looking at whether we could help them to meet physical activity guidelines and whether the intervention influenced their mood, exercise behaviours, attitudes, and dementia risk. Based on current research, the national guidelines recommend at least 150 minutes each week of aerobic activity at a moderate intensity, strength or resistance training at least twice a week, and if they're over 60, balance exercises as often as possible in order to benefit brain health. So let's take a look at what's involved for a participant during the 12-week intervention. Before any exercise, participants received a physical activity guide to read. The guide contained information about the guidelines, the different types of physical activity, how to measure their intensity, safety advice, and tips and tricks for starting and maintaining their exercise. It was designed to be a document that participants could refer back to throughout the program. Participants were assigned an Excel coach who acted as their information and support person throughout the program. In an introduction session, which went for about an hour over Zoom, coaches utilised screen sharing to walk participants through their personalised exercise programs. Each participant's programs were prepared by our exercise expert based on the participant's health information and current and past experience with different types of physical activity. The sessions also covered any personalised recommendations the exercise expert had made and reiterated the information and advice that was found in the guide. The exercise programs were sent to participants via email in PDF format after the introduction session. They received programs for aerobic and strength activity and balance if they were over 60. They were also given a warm-up and cool-down program. Here is an example of what the aerobic program looked like. There were 2 levels of the program that participants could be allocated to, starter and intermediate. And participants could choose between a walking or a cycling program, and also whether they wanted a 3-day or a 5-day program. This example is a starter 5-day program for an older adult. The program gave them a guide for how they could gradually increase the minutes and intensity of their walking or cycling across the 12 weeks, with the aim that towards the end, they would be meeting the guidelines. There were versions of the strength program depending on whether the participant was middle-aged or an older adult, male or female, and at a starter or intermediate level. This is an example of a starter older adult female program. Exercises were set up in circuits and colour coding was used to differentiate exercises for upper body, lower body and core. Along with circuits, participants were provided with a progression guide which gave them an indication of how to increase their strength activity gradually by increasing the number of exercises chosen, their repetitions, sets, load and sessions per week. The ability to choose exercises gave participants who had any physical health issues the flexibility to avoid exercises that might cause them pain or flare-ups. Each exercise in the circuit had a full-page instructional with a picture, detailed instructions and progression options, which gave ideas of how to modify the exercise if a participant was experiencing difficulty just wanted to make it a bit more challenging. A YouTube video link was included, which showed participants how to do the exercise from different angles and using body weights, dumbbells or resistance bands. Balance program for older adults was laid out in a similar way to the strength program.
So I'll go back to the slides again, and I won't show the whole video because there's a bit more to go, but I think it gives a really nice overview of what people were doing, what participants were doing in the Excel program, which was a really Excel study, which was a really exciting study to be part of. And at the moment, results are being analysed, and it'll be very exciting to share the results of that study. And thinking kind of forward to the next project from there, what you might have seen there was that it was a very comprehensive set of resources that were developed for participants. And also it was a fairly, I guess, labour-intensive study to run, in that our research assistants were acting as coaches for all the participants and catching up with them regularly and supporting them through that process. So that kind of segues through to the next project, which is one that I'm currently in the process of setting up as the last part of my PhD, which is trying to design and assess the feasibility and acceptability of a physical activity intervention to reduce dementia risk by increasing physical activity levels and reducing anxiety in midlife and late life adults with clinically significant anxiety. So just as a very brief overview, unfortunately, we're not quite recruiting participants for this study just yet because we're still in process of setting it up, but it'll be kind of running within the next month or two. And what we're trying to do here, which is a little bit different to Excel, is that we've adapted some of the Excel resources and tried to focus a bit more on older adults who have anxiety, given that Excel was a bit broader in that it was depression, anxiety, stress, and cognitive concerns. And we're trying to create a program which which is a little bit less labor intensive, which can hopefully help with our scalability and sustainability and reach for those who are able to do a more self-directed program. So this will be completely online, and they interact with the platform rather than having a regular coach that they speak to, and they also use a Fitbit as part of this project, which integrates with the platform as well. So I would envisage that it's certainly not for everyone, but there will be a proportion of the population for whom this would be something that they would be quite interested in and would be keen to try out, whilst there also be a proportion who really benefit from and appreciate having that kind of human interaction with the coach. This is the team that's busily setting it up. So we're busily setting up the web page with help from our technology investigators, and hoping to have that up and running soon. Given the time, I'll just quickly go through these last few slides, but in terms of the aims, we're essentially looking at acceptability and feasibility, and we're also trying to get a bit of preliminary pre-post data to give us some ideas of how useful it might be, and also to help design a randomized controlled trial for the future. We hope and hypothesize that it'll be feasible and acceptable. I've spoken a bit about the participants that we're trying to recruit, and in terms of outcomes, I've also spoken about the acceptability and feasibility, as well as getting some preliminary ideas about how it improves mental health and dementia risk. The platform will have an intervention which will be similar and adapted from Excel and focused on the anxiety component. We'll have the Fitbit, and we'll have weekly messages that will later become automated post the pilot. So I think in terms of the future, I always am inspired by the quote from Eric Lindsay and Merrill Butters from a few years ago. Our best chance now to combat cognitive decline in the context of anxiety is to use a multimodal integrative approach. This includes physical exercise, mindfulness, and cognitive training. And these are ideal because they have anti-anxiety effects as well as a putative pro-cognitive effect, and therefore are a win-win for anxious older adults. So that always inspires me to keep on working on these things. Very briefly, in terms of resources and the obligatory advertisements that a researcher always puts in, but we have created physical activity guidelines. This is the team there. They're available on our website. There's a link there which is for Australians aged 60 and older who have mild cognitive impairment or subjective cognitive decline. And there's a link there that you can download it at. And there's also on the same website a report which was essentially a review of the literature which helped us to come up with the recommendations. We are living in a bit of a pandemic of anxiety, and that continues to change. So it's a continually evolving situation. And that's just to acknowledge the elephant in the room. We know that there have been mental health changes after previous pandemics, whether it was the influenza pandemic of 100 years ago, SARS in 2003, quarantine has an impact in itself. And we know that older adults have been identified as a vulnerable group during the pandemic. And so that's an important thing for us to keep thinking about. And we've written about this too, given our concerns about this. So in terms of the advertisements that I said, we are recruiting for a different trial called Recover-D, which is looking to help people aged 50 to 75 with mild to moderate depression who are not on an antidepressant and are interested in a psychosocial skills training program in combination with an antidepressant called vortioxetine. I also always advertise the IPA, which is an international association of people interested in older adults' mental health, particularly clinicians who work in the field. And a big thank you, because I've gone over time, big thank you to the CRE for Cognitive Health, which is funded part of my PhD projects that have been discussed, as well as the Department of Psychiatry Innovation Grant for the Extra project, which I've been discussing, and all of my supervisors and advisory committee, and all of the audience who have come along and listened to me being able to chat about topics of great interest to me. Thank you so much. I'll probably stop sharing the slides now.
Thank you, Terry. That was really great. Lovely to have an opportunity to hear from someone who really is an expert in this area, particularly the area of anxiety. And as you mentioned, an area that's perhaps not as well researched and not as well resourced as some of the other areas working with older adults. So we've got a few minutes for questions. I'll just open it up to the floor. Please feel free to go to the bottom of your Zoom bar there and add something into the chat if you want to ask a question that way. Or equally, put up your virtual hand and we'll just throw right to you. I've got as many people on the screen as I can, but if there's someone on the screen and I'm not seeing them, I hope Isabella, who's done such a wonderful job along with Jessica of organising today, and the team at NARI do a brilliant job of pulling this together. I hope someone will point out that there's a hand up that I can't see. Well, while we do that, I might actually just start off, take that sort of chair's prerogative and have a chance for a question if I can, Terry.
Sure.
Considering, we are, whether we're through a pandemic or not, but we're through perhaps hopefully the worst of the pandemic. the role of anxiety in this, the impact that anxiety has on our day-to-day life. Why do you think anxiety is so under-researched, that it is the poorer cousin almost to depression in terms of the amount of focus we give in older adults?
Yeah, it's a really good question, because I've thought about this quite a bit as I was partly complaining about it in the talk that I just gave, and we were thinking about this when we wrote that editorial asking for more worrying to be done about anxiety in later life. And we came up with a few theories as to why that was the case in that editorial. And one of them was more related to age. And there is this kind of belief that because quite a few of the anxiety disorders come on earlier in life, that it's kind of should be targeted more in that age group. But we did talk about how in later life it still has a huge effect on people. Also, there's this sense that anxiety is kind of mild and doesn't cause as much distress or disability as other conditions, for example, depression, which was the comparison on that graph that we used. And I think there's enough out there to show that anxiety, particularly if it's more severe anxiety, certainly causes huge amounts of distress and disability to the people it affects. And it's not a competition anyway between depression and anxiety, because we know depression causes significant distress and disability as well. But it's more to highlight that perhaps there needs to be a bit more attention to the anxiety side of things as well. So they were some of the reasons. There were a few other things around the diagnostic tools as well, and how age-friendly they are. But I noticed there are more questions, so
There are, and thanks for those thoughts, Terry. And also, I want to apologise that I'm not distracted here in the background. I'm just looking at chats and hands up. Yvonne, I can see your hand up. I'm just going to run to one question first from Cobby here in the chat, just to say, Terry, maybe you can speak to the difference between exercise and physical activity quickly, and then we'll go to Yvonne and ask.
Yeah, that's a really good question. And I must say, one of my PhD advisory committee members is an exercise physiologist, so she always answers this much better than I, and always corrects me when I get this wrong. But my understanding is that I guess physical activity is any kind of, and probably there are people in the room who will answer this better than I, but it's kind of any physical kind of movement that we do with our body, whereas exercise is defined by the EPs and the physiotherapists as being more of a deliberate, purposeful, repetitive movement for the sake of, for example, our cardiovascular fitness, or strength, or balance training, which is the other one that's becoming more and more done these days as well, and recommended.
Yeah. I think that's lovely. Yvonne, please, if you wouldn't mind asking your question.
Of course. First off, wonderful presentation, Terry. Perfect. I'm looking at David's question in the chat. We need to do something to change, and I think this is great. So I missed the first 5 minutes, so you might have gone over this, but I wanted to talk about dose response for movement or physical activity, and also location. So I'm from the QT Design Lab, so we're all about the design of the environment. So often there's that conversation about nature and movement, and I'm wondering if that's a factor in terms of could you encourage people to walk through nature, or is that something you're considering?
Yeah, that's a really good question. I mean, I think the gist of it, from my understanding in terms of anxiety, is there's probably not enough data for us to really, there's not enough research evidence for us to give kind of clear-cut recommendations around intensity yet. I mean, I think there's a suggestion from some of the reviews that higher intensity was more beneficial, which kind of makes sense, I think, because that tends to be the kind of finding of a lot of other conditions, and it kind of overlaps a bit with what David was saying, that that there's so much benefit from exercise already, even if we don't have enough RCTs in anxiety, that it should be recommended across the board, because it has so many benefits. I don't know enough about the literature about environment and nature spaces, but I think that certainly, at least qualitatively, from speaking with people that have been in the studies, they certainly, many of them certainly benefit from being in nature and open spaces and being outdoors, rather than in an enclosed space or inside, and that comes out a lot. And it's also one of our strategies that we have in our behavior change list for making the exercise even more rewarding for them. So thank you for bringing that up. I'd love to learn more about your field, actually.
Yeah, well, let's connect later, but I know many of your team, they're great people. But yeah, I'm just looking forward to seeing more as you travel along your journey, because it's really important work. So good job.
Awesome, thank you.
Thank you for that, Terry. David Williams has put a question here, but David, I can see you're on the screen as well. Would you prefer me to read it, or would you like to speak directly to Terry? Oh, just on mute, David. I might ask the question for David, and he might come off mute at some point, but Terry was asking, do we already know enough to foster a big community effort to promulgate exercise along the lines shown amongst the older community? And a really great point, that we really need to respond quickly and try and keep people more functional and out of aged care, which will take years. So you got any comments to that, Terry?
Yeah, I think that's a great question. I think I couldn't agree more with David. I think, I think whilst we are continuing to learn more and more about exactly what it helps with and what's the best way to do it, there's certainly enough knowledge out there for all the benefits of exercise across so many different conditions and different aspects of health, that it really should be a big community effort to get people moving. And we used to have those sorts of things. I remember as a kid, there was the Life Be In It campaign to get us all off the couch. I remember Norm there, so it must have had an impact on me when I was a kid, but I haven't seen that sort of thing as much lately. And, perhaps a combined kind of effort between different levels of government with some of the big NGOs which have conditions where exercise is important, like the Heart Foundation, Diabetes Australia, Dementia Australia, maybe could be a really big concerted approach to work on it, because it certainly has a lot of benefit for all those conditions. Couldn't agree more.
Yes, and I'm noticing.
Can I make a comment?
Sorry, please.
Can I just make a comment?
Absolutely.
I think we really have to get on the road with this, because we just keep seeing that aged care is going to be solved by squadrons of people suddenly being enlisted from nowhere. It won't happen. Yeah. We have to go into self-help mode really urgently.
Yes.
It seems to me we've got a stack of gymnasiums around the place that are not utilised during the day, when older people could, with some guidance, be involved with that. We've got a good information system. We know who they are. We've got the superannuation funds who are desperately trying to engage with their older members, because they have to provide certain investment criteria. So we've got a lot of reasons why this is the time to get on the road and start doing it. I think your trials are fantastic, Terry. I don't put it down. I think we know enough to get the thing going.
Yes.
And if we get ourselves together, we could start it. And it would be a far cheaper exercise than the billions we're throwing at aged care. If we can just keep people out of aged care for 6 months or a year, it would be an enormous contribution. So I think we really sort of ought to get our act together and try and get it on the road. And like we do with any, as I've been experienced in commercial factory operations, work on it while it's going. Nothing will make you react more quickly if you see a problem in the program to get it right. I don't think we're going to hurt anybody, but no one will lose out if we start going sooner rather than later. Thanks. I'll carry on a bit, but that's...
No, David, I think that's great. And I'll just jump in for a second to say that I'm seeing a few things appearing on the chat. The role of COTA, that NARI have some seniors exercise parks work there. So thanks, Susie, for that comment. A few people like myself and Terry remembering Norm and the Life Be In It. So I think we're speaking to a group here that, we're perhaps the ones that need to keep advocating, as we are already. And I know NARI and our academic unit are very key in this space for doing that. We don't have a lot of time left, but there was a question that I want to make sure that we get to. Bear with me. From Vicky Long. Vicky asked you, Terry, as part of your study, will you be looking at the impact of anxiety disorders on eating disorders in older people? And have you found any relevance to this in your literature reviews? Any comments on that? A really interesting area.
Yeah, that's a really interesting question. I mean, to be honest, we hadn't really thought a great deal about that. I'd also be interested to know, I guess, what type of eating disorders you might be thinking of. But I mean, I guess one of the reasons why we haven't thought of it that much is, I work in a clinical practice with older adults, and we don't see that many people with eating disorders, I must say. We see a number, but it's not a huge amount. So I hadn't thought of that specifically or come across that much in the literature, but I'd certainly be interested in knowing more about that and how it could relate as well. I guess the other way of looking at it too is that an important component of lifestyle intervention is about nutrition and diet and having a healthy diet, and I think that often goes hand in hand with being physically active as well. So I think they're important considerations to have in mind.
It's certainly something that we've seen in our Excel study that Terry was speaking a little bit about, and Terry's centrally involved in. But with the uptake of physical activity, we noted a number of our participants saying that they went on then and made changes to their diet. That was unrelated. That wasn't part of the study. And this is something we found in our qualitative work. But, that whole, you start and roll a snowball down a hill and it becomes bigger and bigger. And a few people finding that with their lifestyle effects moving in a positive direction, which is great. So just having a little look here. Vicky was just thanking you there, Terry. Couldn't quite get the unmute working. Totally understand. Now we have Jim sound like a social opportunity too. We've got a comment here, I think fantastic. And from David Sykes, just a point around government has previously funded through Alzheimer's Australia or Dementia Australia to deliver a program focused on risk reduction, which included the importance of exercise, but the appetite for this has shifted, and that he agrees with David about the need to take a more self-help approach. I think that's a really lovely point to put in there as well. And how we are working within this political landscape of what has the current impetus and what doesn't. Really wonderful and rich conversation. And Terry, thanks for spending the time, both giving us the presentation and engaging in this conversation and addressing these questions. We're just on time now, so I think we might need to bring the session to a close, but I just want to personally thank you, Terry, and everyone for being really involved in this virtual space. It's been a delight for me today as someone who's interested in older adults and anxiety myself. I've found it really informative and helpful. So we'll bring the session to a close and with my thanks. And next session, please do join us. I'm just checking it's Dr. Catherine Kenny we have on the 9th of May at 12 p.m, same place. So please come along and listen to that. And if you can join me perhaps with the reactions button with a clap if you can, or, a little clap there just to thank Terry. I really appreciate your presentation. Thanks. And thanks, everyone.
Thanks, everyone.